This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1, questions 1 to 12. You will hear an occupational therapist speaking with a new patient, Meniere. For questions 1 to 12, fill in the blanks in the notes with a word or brief phrase. You now have 30 seconds to review the notes.
Camille's call, isn't it?
Yes, that's right, Mia Cole.
I see you've been referred to me for carpal tunnel syndrome. Let's go over your history. I'd like to understand when the symptoms first started, how they've progressed, and what treatments you've tried in the past. Could you describe your previous episodes and what helped at the time?
Sure. It all started about 18 months ago. When I first noticed discomfort in my wrist, I was in the middle of a particularly demanding work week, spending long hours typing without many breaks. Initially, I brushed it off as fatigue, but as the days went on, the discomfort worsened. I took short breaks and stretched my hands, and eventually it eased up. But I had occasional flare-ups after that.
And when did it become a more serious issue?
About a year ago, I started experiencing persistent numbness and tingling in my wrist and fingers. It wasn't just discomfort anymore, it felt like something was off. The symptoms took nearly 6 months to settle down. And just when I thought it was behind me, I noticed a recurrence about a month ago. This time, the symptoms have been more severe and disruptive.
That sounds frustrating. Where exactly are you feeling the pain now?
It's mainly in my right hand. The pain starts at my wrist and travels up to my fingers, sometimes even extending toward my forearm. It's been particularly difficult because I'm right-handed, so it affects nearly everything I do.
On a scale from mild to severe, how would you describe the pain?
At its worst, it's unbearable. Some days I can barely hold a pen or a cup of coffee without dropping it. Typing, gripping objects, even using my phone, it's all difficult. The most frustrating part is that my hand sometimes feels completely numb. Yet at other times, there's this buzzing sensation in my fingertips, almost like an electrical current running through them.
That sounds like classic nerve compression symptoms. What treatments were recommended when you first sought medical advice?
At first, my doctor prescribed NSAIDs to help with inflammation and pain relief. I was also advised to wear wrist splints, especially at night, to keep my wrist in a neutral position. They helped somewhat, but I still struggled with daily tasks. Eventually, my doctor referred me to a chiropractor, but honestly, I didn't notice much improvement from those sessions.
Did you try any other interventions?
Yes. After seeing a hand specialist, I was advised to undergo joint mobilization therapy, along with a structured hand exercise program to improve mobility and reduce nerve compression.
Did you receive any medical treatments beyond physical therapy?
Yes. I was given a corticosteroid injection directly into the wrist. It helped reduce the inflammation significantly, but the relief wasn't permanent. I also tried ultrasound therapy and electrical nerve stimulation. At one point, I considered acupuncture, but by then my symptoms had already started improving, so I decided not to pursue it.
Looking back, which treatment do you feel was the most effective?
Honestly, there wasn't a single miracle cure. It was the combination of treatments that made a difference. For the first 4 months, nothing seemed to work, but by the 5th month, I started noticing real progress. The combination of medication, therapy, and lifestyle adjustments ultimately led to recovery.
That's great insight. Were any lifestyle changes recommended to prevent future issues?
Yes, they mentioned that my condition was likely due to repetitive strain from my job. I've been more mindful about taking breaks and adjusting my workstation ergonomics. But apart from that, I was relieved to hear that I don't have underlying conditions like arthritis or neck pain that could be contributing to it.
Extract 2, questions 13 to 24. You will hear a neurologist speaking with a new patient, Ethan Clark. For questions 13 to 24, fill in the blanks in the notes using a word or short phrase. You now have 30 seconds to review the notes.
Coming, Mr. Clark, correct?
Yes, that's right. Ethan Clark.
I understand you've been referred to me for chronic migraines. Have you been dealing with them for a long time?
Unfortunately, yes. This isn't my first rodeo with them. They've been disrupting my life for quite some time now.
Let's go over your history in detail. Can you describe when your migraines first started, how they've evolved, and what treatments you've tried so far?
It all started about 18 months ago during a particularly intense work project. I was under a lot of pressure to meet deadlines, and my work required me to be in front of a screen for up to 12 hours a day. At first, I had occasional headaches, but they were manageable. However, after about 1 year, I started experiencing full-blown migraines. They would come in waves. Some weeks were fine and others were unbearable. After about 6 months, the migraines seemed to settle down, but unfortunately, they made a recurrence last month. And this time, they've been much worse.
Did your general practitioner confirm that these were migraines and not another type of headache?
Yes, my GP diagnosed me with migraines after a thorough evaluation. The pain is always located behind my left eye, and it feels like someone is hitting me with a hammer. It's relentless. The worst part is that it's not just pain. I also experience extreme sensitivity to light and sound, nausea, and sometimes dizziness. On bad days, I can't even drive because my vision gets distorted. And when an attack hits, it's impossible to meet deadlines or focus on work. I also experience aura before an episode, flashing lights, blind spots, and sometimes even blurred vision, which makes it even harder to function. I work as a software developer, so avoiding screen time is not exactly an option for me.
That sounds extremely disruptive. What treatments were initially recommended to help manage the symptoms?
At first, my GP started me on NSAIDs, but they only provided mild relief. When the migraines became more severe, I was prescribed triptans, which helped to some extent, but the pain was still overwhelming. I also tried cold packs on my neck and forehead, and while they offered temporary relief, they didn't stop the migraines from happening. My GP then referred me to a nutritionist to explore possible dietary triggers, but unfortunately, changing my diet didn't seem to have any significant effect. Later, I was sent to a pain specialist who suggested focusing on posture adjustments and specific eye exercises to reduce strain, especially since I spend so much time in front of screens.
Were any other treatments or therapies attempted?
Yes, I underwent Botox injections, which were supposed to help reduce the frequency and intensity of the migraines. I also started taking magnesium supplements, as I read that magnesium deficiency might be linked to migraines. In addition, I tried this cranial massage therapy that was meant to relieve tension and improve circulation. I even considered acupuncture at one point, but by the time I was ready to try it, the frequency of my migraines had already started to decline. So I decided not to go forward with it.
Looking back, what do you think made the biggest difference in managing your migraines?
It's hard to pinpoint a single treatment that worked best. For the first 5 months, nothing seemed to make much of a difference. Then, all of a sudden, things started improving. I think it was a combination of Botox injections, reducing my screen time, and practicing meditation that finally started to work. Once I implemented all of these consistently, the migraines became less frequent and more manageable.
That's promising. Were any lifestyle changes recommended to help prevent future attacks?
Yes, we discussed how stress and excessive screen time were major triggers for me. My doctor also emphasized the importance of maintaining good posture, especially while working long hours at a desk. Apart from that, they ruled out other potential factors like high blood pressure or sinus issues, so at least I don't have to worry about those contributing to the migraines.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. Question 25, you hear a nurse briefing a colleague about a patient with Meniere's disease, inner ear disorder causing vertigo. Now read the question.
Mr. Hale was admitted last night with acute vertigo and tinnitus. He's a 58-year-old male with a known history of Meniere's disease, which has been causing recurrent episodes of dizziness and hearing disturbances. He has no known drug allergies, but he is prone to sudden drops in blood pressure, which puts him at an increased risk of fainting. His balance is significantly impaired, and he has already stumbled twice this morning, though fortunately without injury. Given his risk of dehydration, we have discontinued his diuretic, which was initially prescribed for fluid regulation, but is now contributing to excessive fluid loss. He is currently on a low-sodium diet to help manage his condition, as well as anti-vertigo medication to alleviate symptoms. Oxygen is on standby in case of syncope, though his oxygen saturation remains stable at 97% on room air. We'll need to continue monitoring his blood pressure closely, ensure fall precautions are in place, and reassess his response to medication throughout the day.
Question 26. You hear a care home manager addressing nursing staff about errors in dispensing antipsychotic medications in a dementia unit. Now read the question.
A recent audit indicates a notable 30% diminution in procedural inaccuracies following the implementation of the double-check protocol. Nevertheless, discrepancies persist, warranting further scrutiny. Data analytics pinpoint that an overwhelming 70% of residual errors transpire during morning medication rounds, predominantly attributed to expedited workflows under time constraints. A critical variable exacerbating this issue is the frequent interruptions that occur during the preparation of controlled substances, thereby heightening the likelihood of lapses. To mitigate this, I strongly urge adherence to established protocols, specifically by utilizing the designated quiet room for such tasks to ensure uninterrupted focus and precision. While omissions related to allergies are infrequent, the potential repercussions necessitate meticulous verification of patient charts as a non-negotiable safeguard. Conversely, the incidence of late-day discrepancies is markedly diminished, ostensibly due to the reduction in environmental stimuli and a less frenetic operational tempo. Moving forward, a concerted effort to streamline morning procedures, reinforce adherence to designated spaces, and uphold rigorous verification processes will be pivotal in eradicating residual inefficiencies.
Question 27. You hear a morning briefing in a hospital ward about a patient with Huntington's disease, neurodegenerative disorder. Now read the question.
Let's discuss Mr. Patel in bed 7. He's a 42-year-old male with Huntington's disease, admitted due to worsening chorea and episodes of aggression that have become difficult to manage at home. His involuntary movements have increased in severity, putting him at high risk for falls and injury, so he will remain in the neurology unit until his condition stabilizes. Given his neuromuscular decline, his swallowing ability must be assessed hourly to monitor for aspiration risk and potential dysphagia complications. His emotional ability is also a concern, as he has exhibited rapid mood shifts, which could escalate into further agitation. Tomorrow, The genetics team will meet with his family to assess their hereditary risk and provide counseling. Additionally, social services are working on home modifications to support his long-term care, but this is currently on hold pending consent from his brother, who is his primary caregiver. For now, the priority is ensuring his safety. Strict fall precautions must be in place, and there should be no patient transfers without direct supervision. Staff should be mindful of his impulsive movements and maintain a calm, structured environment to minimize agitation.
Question 28. You hear an antenatal consultation at a GP practice with a patient planning a water birth with fibromyalgia. Now read the question.
Miss Quinn, I see from your birth plan that you're hoping for a water birth. That's a great option for relaxation and pain management, but given your fibromyalgia, have you thought about what pain relief strategies might work best for you? Some women with fibromyalgia find that certain methods provide better relief than others, especially since chronic pain conditions can sometimes lead to heightened sensitivity during labor.
Yes, I have been thinking about it. But I'm a bit concerned about triggering a fibromyalgia flare during labor. Last time I used gas and air, nitrous oxide, which helped, but I've recently heard that TENS, transcutaneous electrical nerve stimulation, machines, can be really effective for pain management. Would I be able to use one while I'm in the birthing pool?
That's a great question. TENS can be beneficial for managing contractions, but unfortunately it isn't safe for use in water since it relies on electrical impulses. However, there are still several pain relief options that could work for you. We could consider pethidine, which is an injected opioid that provides pain relief without requiring you to leave the pool. Another option is using a warm compress on your lower back or abdomen, which many women with fibromyalgia find soothing. If at any point you decide you need stronger pain relief, such as an epidural, you would need to leave the water, as epidurals require continuous monitoring and an anesthetist supervision. That said, there are also alternative techniques, such as guided breathing, hydrotherapy movement techniques, and aromatherapy that might help you manage pain while staying in the pool. Let's go through all your options together and see what aligns best with your preferences and condition.
Question 29. You hear a trainee doctor reporting a problem about a patient with Stevens-Johnson syndrome, severe skin reaction. Now read the question.
I initially prescribed antibiotics for Mr. Lee's cellulitis, following standard treatment protocols. However, within a short period, he developed a rash and mucosal ulcers, suggesting a possible adverse drug reaction. Concerned about a potential allergy, I immediately reviewed his medical chart, but there were no documented allergies to any medications. Upon further investigation, I discovered that Mr. Lee had a similar reaction in the past to sulfonamide antibiotics, but this critical information had never been officially documented in his records. Given the pattern of symptoms, it is highly likely that the current antibiotic regimen contained a sulfonamide component, inadvertently triggering a recurrent hypersensitivity reaction. Moving forward, I have updated his medical records to reflect this newly identified drug sensitivity, ensuring that future treatments avoid sulfonamide-based antibiotics. I've also initiated appropriate supportive care to manage his symptoms and will explore alternative antibiotic options to treat his cellulitis safely. This case underscores the importance of thorough medication histories and the need for comprehensive documentation to prevent similar incidents.
Question 30. You hear a doctor assessing a teenage boy's ankle with suspected Lees-Frank injury, midfoot fracture dislocation. Now read the question.
So you landed awkwardly while playing rugby, correct? From what I can see, The swelling and bruising along your midfoot arch are concerning, and they suggest a Lisfranc injury, which involves damage to the ligaments or bones in the midfoot. This type of injury can range from a mild sprain to a serious fracture or dislocation. So we need to assess the severity. Does it hurt when you push off your toes or try to bear weight on the foot? That's often a key indicator of the extent of the injury.
Yeah, it's a sharp, stabbing pain, especially when I try to walk or push off. I can't put much weight on it without it hurting a lot.
That confirms my suspicion. A Lisfranc injury can be tricky because it often doesn't show up clearly on a basic exam. So we'll need to do an x-ray to check for fractures or misalignment of the tarsal and metatarsal bones. If the bones are out of place, meaning the injury is more severe, surgery will be required to realign and stabilize the foot. If it turns out to be just a sprain without significant displacement, we can manage it with immobilization, meaning a cast or walking boot, and strict rest, elevation, and ice therapy. However, given your symptoms and the extent of bruising, this seems more complex than a simple sprain, so we'll proceed with imaging right away to determine the best course of action.
Part C, Extract 1, questions 31 to 36. You hear an interview with a cardiologist called Dr. David Clarkson, who's an expert on Bruno disease. You now have 90 seconds to review questions 31 to 36.
Today, we're talking to Dr. Clarkson, a cardiologist and Bruno disease specialist in the USA. Dr. Clarkson, can you explain what Bruno disease is and why it's often referred to as a neglected disease?
Bruno disease is caused by a parasite called Trypanosoma burneat. Most people get infected when they are bitten by an insect commonly known as the midnight bug, which carries the parasite. Unfortunately, people often don't even realize they've been bitten. During the initial phase, symptoms are usually mild or absent. Around 70% of infected individuals never develop complications. However, the remaining 30% experience a long silent phase, sometimes lasting up to 30 years before the disease progresses into a chronic stage. This chronic phase can cause serious cardiac, digestive, and neurological disorders. It's estimated that around 7 million people worldwide have Bruno disease, but it receives little publicity or funding for research. This lack of attention is mainly because it is a disease of marginalized communities in Southeast Asia, where it is endemic. Unfortunately, without significant resources, it is difficult to drive action against the disease.
Right, I see. But are there any concerns about Bruno disease in the USA?
Yes, the midnight bug, which transmits the parasite, is actually endemic to the southern U.S. states. However, since 1955, only around 30 people have been bitten and infected while in the USA. The real concern, though, is that a large number of first and second generation immigrants from Southeast Asia already carry the disease. The current estimate is around 300,000 people. While Bruno disease isn't contagious from person to person, except in congenital cases and possibly through blood transfusion, A significant proportion of those infected develop chronic complications later in life.
And for the benefit of our listeners, can you describe a specific case?
Certainly. Earlier this year, a Cambodian woman, I'll call her Marisol, came to my clinic requesting a Bruno disease test. She has been a long-term U.S. resident, but she recently visited Cambodia on vacation. While she was there, she felt unwell, which she initially attributed to changes in diet and environment. Interestingly, she had planned to donate blood in Cambodia, but at the last minute, she decided not to. Ironically, if she had gone through with it, routine screening would have detected Bruno disease. Later, after hearing from relatives that Bruno disease can be passed from mother to child, she decided to get tested because she and her partner wanted to start a family. Unfortunately, tests confirmed that she was in the intermediate stage of Bruno disease.
And what challenges do you face in treating Bruno disease?
One example is Jennifer, a patient who had just returned from a trip to a Bruno endemic region when she began feeling unwell. Tests confirmed that she had Bruno disease. She was then referred to my clinic for further evaluation. Meanwhile, Jennifer researched Bruno disease online, and as you can imagine, she was very distressed by what she read. She once asked me, why me? FIBA is she was also worried about taking Brunozole, the primary drug used to treat Bruno disease, because it has potentially harmful side effects. For optimal effectiveness, Brunozole should ideally be taken within the first 2 months of infection. However, by the time Jennifer's testing was completed, 10 weeks had already passed since the likely time of infection. Fortunately, she decided to proceed with treatment and tolerated the medication well.
And do you also treat patients in the later stages of the illness?
Yes, for example, one of my patients, Juan, is 62 years old. 8 years ago, he was diagnosed with dilated cardiomyopathy, a condition that weakens the heart muscle. Tests at the time also confirmed that he had Bruno disease. If Juan had been tested earlier in life, we could have managed his condition more effectively. A year after his Bruno diagnosis, he also developed type 2 diabetes, which complicated his treatment. Although his diabetes was eventually managed, his body initially rejected insulin therapy. For several years, heart medications helped keep his condition stable, but over time, his heart function deteriorated significantly. Unfortunately, this is a typical progression in patients who have been living with Bruno disease for many years. At this advanced stage, there is no cure. The best approach is to focus on rest, light exercise, and a carefully managed diet to slow down further deterioration.
Well, Speaker 1, thank you very much for sharing your expertise with us today.
Extract 2. Questions 37 to 42. You hear a lecture by Dr. Eleanor Grant, a neurologist specializing in Kessler syndrome. You now have 90 seconds to read questions 37 to 42.
Speaker 1, good afternoon. Today we'll discuss Kessler syndrome, a rare neurological disorder caused by the Kessler virus, transmitted through the bite of the Aedes nocturnis mosquito. First identified in 1995, this disease remains under-recognized despite its devastating impact. Why? Because it disproportionately affects remote indigenous communities in Papua New Guinea and Northern Australia, populations with limited healthcare access. Global funding agencies often overlook these groups, branding Kessler a neglected disease. In Australia, recent concerns aren't due to mosquito proliferation, but to enhanced serological testing. Over 1,000 asymptomatic cases were detected last year alone, many in immigrants from endemic regions. While the virus isn't contagious person to person, blood transfusions or organ donations from carriers pose risks. Dave Liam, a 28-year-old construction worker. He sought testing after learning his upcoming volunteer trip to Papua New Guinea required blood donation. Routine screening flagged the virus, which he likely contracted years prior. Early detection allowed us to halt his donation, preventing transmission. Treatment challenges abound. The antiviral Keslivier works best if administered within 30 days of infection. However, delays are common. Sophia, a 34-year-old teacher, dismissed her initial fatigue as a stress. By the time she sought help, 12 weeks post-infection, Kesliver's efficacy was reduced. Her case underscores the need for public education. In advanced stages, Kessler manifests predictably. Mr. Nguyen, 60, developed tremors and memory loss a decade after infection. Last year, liver cirrhosis emerged, a hallmark of late-stage Kessler. While antivirals slowed progression, his case mirrors most long-term patients. Irreversible neurological decline. Looking ahead, our priority isn't mosquito control, a long-term goal, but reformulating Kesliver. Current tablets are impracticable for children in endemic areas. A liquid or dissolvable form could save countless young lives. Thank you.